Good morning. How are you? So we'll talk to the. Tiffany asked me to talk about kind of ventilation and more specifically about jet ventilation, which occasionally we do here. But I'll kind of go over the techniques for ventilation in thoracic cases. Some of it will be something that we see almost every day, and it's like 99% of the time. And then there are some more unique circumstances where we have to vary what we do given the patient pathology. So a couple things. You know how you can do a PowerPoint presentation? It kind of gives you possible formats. So if you do jet ventilation, it automatically puts a little plane there. Ouch. That was kind of interesting. So we'll review ventilation techniques which happen during thoracic surgery, from the things that we do pretty much every day to things which sometimes happen like maybe once every 2 years. And then more specifically, spend a little bit of time on jet ventilation. It's pretty uncommon. It is hard. It's because it's uncommon and it uses a little bit different physiology and physics parameters. It's a little bit hard and not very counterintuitive if you think about how we used to seeing patients being ventilated. And then a couple things when you can anticipate: are we going to use jet ventilation or not use jet ventilations in some of the applications and benefits? So some of the history, I think it's always interesting to have history background. Airway interventions, mostly as an emergencies, were done for thousands of years. Having said that, as emergency airway is very high risk and a very morbid procedure. So a lot of patients a lot of people did not survive if they did aspirate a big it's a big bone that completely occluded the airway, if they have infection that completely collapsed the airway. But there were some successes. So first endotracheal tube describant was used in 1930s. This is first time when someone actually managed to put something in the airway purposefully and ventilate the patient kind of on a more elective basis. So this is not that far, that's not very long ago. And what we use for a modern endotracheal tube, specifically for a double lumen tube, it only was kind of discovered or described and invented in 1960s. And here you can see a picture. So this is from one of the older textbooks from like 1500s or something, where how they describe how do you do this emergent tracheostomy essentially. Interestingly, as these things got discovered and recorded over hundreds of years, you can see that over 300 years, only 28 successful procedures were discussed that we know that we have track of. There are possibly some other ones, probably not very many. So ventilation during thoracic procedure, just like with pretty much anything else, this is how we deliver anesthesia. And the goal is that during surgery, pretty much any surgery, you need to have it so that the patient is not moving and you have exposure of your operative field. In thoracic surgery, we're operating typically on the chest, on the lungs, or somewhere in the airway. And airway becomes a little bit more unique because this is how we deliver ventilation and oxygenation. It's hard from this angle to see it. And then at times, ventilation becomes tricky, especially if you actually need to operate right where then the tracheal tube is going to be. And this is where the jet ventilation is going to come in, and we'll talk about it in a couple of minutes. Some of the pictures, the picture on the left, the black and white one, this is what the first endotracheal tube looked like. It's very kind of similar to what we use right now, but it's just made out of a little bit different material, and some of the things just kind of looks a little bit more crude. But this is from end of 1920s when it was first time described. This was first time it was being used. And then this is what we use right now. We use double lumen tracheal tube. It's the one that's in the middle. We have rigid bronchoscope for ventilation in certain instances. In addition to double lumen, sometimes we use endobronchial blocker, which is used with the single lumen endotracheal tube. So depending on what we're going to do for surgery, we may have to use one way of ventilation or the other way. So the lung resection, which is what we probably do, probably like 97% of the time plus. And this is the picture on the far right. we do not need to worry about the airway. So airway can be managed the same way it's used in is managed in the majority of all other surgeries. But when you have an endotracheal tumor obstructing the airway, though you can't even place the endotracheal tube, you have to be a little bit more creative. So this is where we start using a little bit different methods. So typically, what happens when the patients go under anesthesia? They get intubated, then the tracheal tube gets connected to through the circuit to the machine, which is going to drive gas and oxygen and the mixture, whatever mixture of gases, oxygen and other ones. It's going to deliver through one of these corrugated limbs right here. It's going to push some air into the patient, and then it's going to get driven out of the patient. So everything is completely contained and completely closed. Whatever gas that gets put into the patient, the same similar gas gets taken out. There is no opening. In fact, if you open the system and you disconnect, there is a disconnect on the tube, there is a hole somewhere. If any of these components come apart, you're not able to do this because all that air that you're trying to put in is going to leak out through that hole. With the jet ventilation and with the rigid bronchoscope, it's a little bit different. First of all, the rigid bronchoscopy that we use, this is one of the methods to use jet ventilation, and this is what I usually have used it with the bronchoscope. It's a tube that's typically smaller than the trachea. When it gets placed in, you have extra space around it, so you do not have a completely contained system anymore. So even if you try to push air into it, there is going to be plenty of space when the air is going to try to leak out. So to modify this, there are multiple modifications. And historically, at the very beginning, and this was being used, you had to have essentially their mouth, the oropharynx. So patients would get this, then they would get like massive packing into their throat, so that all that air that's trying to leak back is not able to really leak back. So you can actually push that air into their lungs. So this is an open circuit. Even if you try to push more air into it, it's going to leak out more. So you have to monitor you have to play this balance in between. You can, in certain circumstances, so with certain modifications, you can try to make it into a closed system and try to ventilate it the same way that you would normally do it. But again, it's you have to be really careful and really patient. And what I've seen happen sometimes, the anesthesiologist who's not quite used to it will go into this mode, and then they cause significant barotrauma when the lung ruptures and collapses and causes pneumothorax very rapidly. And that in those situations becomes a really unstable situation very quickly. So I prefer that we only use jet mode of ventilation here because it's significantly safer. And we'll go through the whole, through the discussion of what jet ventilation is. The typical, just to kind of go over, Susie, you've seen the bronchoscope. We've gone over it like many times as we search for it. But this is what the rigid bronchoscope is. It's just a tube. It's a metal tube that you place in the patient with an extremely hyperextended neck. So not every patient is able to undergo that procedure. If the patient has limited neck mobility, they had surgery or any other reason, they have kyphosis or any abnormalities where they're not able to stretch their neck very far, which essentially lines up your trachea with your mouth in line, you're not able to do it. With a traditional endotracheal tube, we kind of able to retract this, and with the curvature of the flexible tube, you're able to accommodate that, but not with rigid bronchoscope. And then there are a couple attachments which get connected to different things. So there is a line that's going to monitor your pressure, so you can see if you're delivering enough or not enough. Can you increase pressure? Are you giving too much pressure as you're injecting that air? Are you injecting that air under too much pressure? Then there is the line that supplies oxygen as you're kind of pushing all that air into it. And then this is the main working channel right here through which you're actually able to visualize and then do your intervention, whatever that is. So type of ventilation, the jet ventilation and then standard ventilation. There's kind of some of the comparisons here. With the standard ventilation, you typically have, you've seen those kind of bags, bellows bags, which are being squeezed, or the machine's just kind of trying to deliver typically certain volumes. So it's between 300 to 500 cc's of air mixture gas that gets pushed through the endotracheal tube. You can deliver inhaled anesthesia during that time. This is what keeps patients asleep during the surgery. It also removes CO2 as the gas kind of circulates through, and then you need to remove it back. And this ventilation can be sustained from hours to days to weeks. This is patients who, when they go to the intensive care unit, they get put on the same thing, and they get supported until the lungs recover or they're ready to be extubated. With the jet ventilation, it's a little bit different. The delivery of air is in small, very short bursts, but they're driven with pretty high pressure, anywhere from 20 psi to 50 psi that you can deliver that. Frequency varied. You can go from 10 to 12 breaths per minute, which is what we're breathing normally, to much higher, the very high frequency jet ventilation, where you're giving 300 breaths per minute, but they're given at like just couple cc's of volume. So it's essentially like just a steady push of air getting through the endotracheal tube. You're not able to give inhaled anesthesia. So all the anesthesia during that procedure has to be given through IV, and you need to monitor kind of balance between patient being sedated, paralyzed, or not paralyzed, so that they're not moving during the procedure. During that mode of ventilation, it's a lot harder to remove CO2 efficiently. So it's not uncommon that if procedure takes longer, that the patient starts building CO2, and therefore they're starting becoming kind of a little bit, their saturation start going down. And due to this, there is a limit how long you can do this procedure. You can probably do it for a couple hours, maybe 2 hours, maybe a little bit longer, but this is not something that you are able to support patient through multiple hours or days. So this is done specifically in the short-term circumstances to accomplish a particular goal. Yes.
So if your surgery had to go longer than several hours,
right,
then what do you do?
We'll go over it, but in general, you use a combination of modes. So you start with your traditional, then you get to the point where you need to really, for the patient, to not have ventilation across the field, or you can only ventilate a certain portion of lung and not the other portion. So you institute that mode at that time for half an hour, for 45 minutes, for an hour, until you resect it, anastomose it, and now you go back to your normal ventilation. So some of the applications, okay, standard ventilation, you can do it on everybody. It's from doing, I don't know, like inguinal hernia repair to abdominal surgery to pretty much chest surgery. And pretty much in 99% of the thoracic surgery, we just do normal ventilation, standard ventilation. Jet ventilation, as I mentioned, in certain circumstances, with airway obstruction, when you have a lumen that's maybe the size of a pea, or maybe even smaller when you're trying to ventilate the patients through that very small hole. Open airway, when you're trying to, there is a fistula, there is an injury in the airway, there is a big hole in the airway through which as you're trying to deliver air, that air leaks out through that hole and goes everywhere, goes into the chest and the mediastinum. It's a tracheoesophageal fistula. Again, as you're trying to push the air in, it goes through that hole into the stomach. Now, double lumen. So you know how, like, when the patient gets in, thoracic patient gets in, gets placed on the table, and then there is probably about anywhere from 10 minutes for intubation to maybe like 25 minutes for intubation. And sometimes it's only like a minute long, and it's done, and we're happy and we move on. And there are other times when we do a lot of manipulation. Tube in, tube out, push in, push it out, take the cuff down, blow this cuff up, bronchoscope again, need more suction. Like, there is just a lot of back and forth until happy with positioning. So what is double luminal tracheal tube? It's a tube. It's larger in size than the usual endotracheal tube that's used for any other surgery. It has 2 lumens. Both of these lumens are smaller than the usual endotracheal tube. But the position is such, it's designed such that one lumen is a little bit shorter, one is a little bit longer. Typically, this is a left-sided endotracheal tube, and this is, again, we use this one probably 99% of the time when we do use this. So when it's positioned correctly, this is how it's supposed to sit. It's going to sit with the longer lumen with the longer lumen, it's going to be sitting in the left main bronchus. This is called bronchial lumen. And then the shorter lumen is going to sit a little bit above the split in the trachea. This is the tracheal lumen. And as you can see, there are these two balloons. One is blue, one is white. And then you have two attachments here through which you inflate these balloons. One is blue, one is white. B for bronchus, blue, B for bronchus. This is how you can easily remember this. The position sometimes can be very straightforward and other times can be kind of tricky. The modifications of this endotracheal tube are the following. If you search for double endotracheal tube, you'll come up probably with at least 6 other versions of it with slight modifications. There is a right-sided endotracheal tube, which is essentially almost a reverse of this, so that the longer the bronchial lumen is sitting on the right side. You have to position it specifically so that it does not occlude this upper lobe bronchus. Because you can see, if you just flip this over here, this is not going to be ventilating this side. So there is a modification for that. There is a wide tube where it basically sits kind of like this, so that you can just ventilate left and right side without really worrying very much whether you position it correctly. But again, all of these variations take time to understand the limitations and understand some of the details. How do you confirm that it's positioned correctly? How do you troubleshoot it? What to expect when there is a problem? And the technique for intubation is this. Those who come into thoracic cases, you probably noticed some of this, but there are two kind of main thoughts how to do this. I'm not sure why the blind method is being taught anymore at this time in this country. It's possible that in some other place and some other time, it's still used. Right now, there is no way someone's going to tell me, yeah, tube is in good position, and I'm not going to use bronchoscope to confirm that. So we use this basically, and the tracheal tube gets placed partly in. Then you remember how there is a little deviation to one side on the blue, on the longer lumen, and then you rotate it to the left side, kind of hoping that you're gonna get that curvature appropriately positioned, so when you push it in, it's just gonna slip on the left side, and then you're gonna hold it there. I find it so much easier. You kind of, once anesthesiologist does this, just put the scope in and watch it go in where it's supposed to go. Probably half the time, I think we just get lucky and you push the tube and it sits where it's supposed to. And the remaining half the time, you have to still manipulate this. You have to advance it, you have to push it. It did not rotate enough, it over-rotated too much, something else, something else, something else. But eventually, you want to achieve that position so that you are able to ventilate each side separately. And depending, even though it's called left-sided double lumen tube, we ventilate left or right side. It doesn't matter. This directionality does not impact how you ventilate. You can ventilate left side, right side. You can switch from one to another. That part doesn't matter. Some of the things which happen very frequently as we position the tube, when to place the patient in the lateral position, and then we use it, and then suddenly anesthesiologist says, I have high pressures, I can't ventilate. So what happened, the tube with all this manipulation, kind of moving patient up and down, side, and attaching them to the bed, what happened, the tube got pulled back. So, and if the tube gets pulled back, that blue cuff that's supposed to sit right here and only isolate left side got pulled out, and now it's expanded and it's blocking the tracheal lumen from pushing air in. So as you're trying to push air in through here, now the air has to travel through much narrower space, and that's why the pressures start going up. I've seen it so many times that when I hear it, I know what needs to happen. So you usually say, just push it in a little bit, and just pushing it like a centimeter in is going to replace this and push everything back in here in place and expand that lumen out, open up that lumen. Or the opposite can happen when as you're trying to manipulate the patient, the tube migrates too far in. It can either migrate too far in here, or it can migrate too far in here. So now, depending which side you thought you were going to be down on, if you're going to be down on, if you wanted to go down on the right side in this position and you clamp the tube and you're not ventilating, you're only ventilating like one lobe. So the patient's going to desaturate very fast. If it's the other side, it kind of doesn't matter. But still, usually this limits what you're ventilating. So now instead of ventilating just half the lung, you're ventilating maybe one or two lobes. Leads to problems. This usually takes a little bit longer to figure out just because patients get pre-oxygenated and the saturation doesn't drop as fast. It takes usually a couple of minutes. Again, with bronchoscopic view, you can see what happened. You can put the scope in through one or through the other and realize that you are not seeing anatomy that you're supposed to be, and this is how you're able to adjust. And the bronchial blocker is another thing that we use sometimes. I don't like using it. I'm not used to using it as much. Therefore, I say I don't really like using it. But in certain circumstances, it's going to give adequate isolation for what you're going to do, and you don't need to re-intubate the patient. For example, it may be someone who's coming from the ICU who already has an existing endotracheal tube, and you don't necessarily need to take that one out, replace another one in, and then at the end of the case, you take the double lumen out, put another one in. So it's just a lot of airway manipulation. And depending on what you're going to do, you can achieve the control of the airway with this method as well. So basically, and the standard endotracheal tube that goes here, and then you use this catheter on the end of which is a balloon that you push in, and you place it whichever side there is that you want to place it. You can direct it to the right side, you can direct it to the left side, and inflate it, and that's going to be your isolation. And then you have all these kind of attachments which make it so that you can secure it at the endotracheal tube, so that balloon does not kind of go migrate too much during the operation. One of the problems sometimes that happens with this is when you have the balloon in the tracheal tube, since the lumens are larger, it is much easier to allow lung to become atelectatic when it collapses. All that air that's sitting in the lung will decompress as you open that area so that you can actually see inside and do the surgery. But with this, because this is much thinner, that air takes longer to kind of come out through this blocker and decompress. But in circumstances where you do impairment when the lung is already collapsed, that kind of is not very relevant, and it expedites some of the things. Also makes it a little bit easy, kind of save some of the manipulation on the airway, because each time we kind of manipulate airway, it becomes more edematous and gets traumatized. Other things that we use sometimes, and this is when maybe patient has a little bit more challenging airway, you're trying to place a double lumen, which is a little bit more rigid. It has a little bit less flexibility than the single lumen in the tracheal tube. You're just not able to place it through the vocal cords for whatever reason. It may be that the chin is too receded, or something like this. So in those situations, you kind of do an additional step. You can intubate the patient with a single lumen, and then use these exchange catheters to guide your exchange afterwards. So basically, you place the endotracheal tube, you confirm that you're in a trachea, then you put one of these catheters, which are really long, they're probably about this long. So you place the catheter through the endotracheal tube, push it pretty far in. Then over that, you pull out the endotracheal tube while the catheter remains in the airway. Once it's out, now you kind of thread the double lumen endotracheal tube over it and push it in the place. So all these things just kind of meant, all these methods are kind of meant to, were designed to essentially ensure that we are able to ventilate the lung appropriately with do selective lung ventilation and selective lung isolation. This can be used for pretty much anything. At the end of the case, if we need to exchange the endotracheal tube, sometimes we'll also do the same thing in reverse. Now from double lumen, we'll go to a single lumen, especially when you know that the intubation was trickier, it was more difficult, and you want to make sure you have some sort of access and control of the airway. So now jet ventilation, which is not commonly used. I think here we've used it maybe like 3 times, something like that. Just as I mentioned before, it's typically for in a situation where there is an opening in the airway. Either the opening already happened there is an injury, there is a fistula, or you plan to make that opening. And you need to still ventilate, and the lung stays on the opposite side of that opening. So you need to make sure you deliver air past that opening, past that hole, into the lungs for adequate oxygenation. Stenosis is another reason to do this. So when the airway is so tight that where you're trying to kind of insufflate and push the air in, there's going to be a lot of resistance as it's trying to go through the very small opening in the hole. So with jet ventilation, it changes physiology and you're able to deliver it better. So this is what the jet ventilator looks like. Again, I mentioned this before, just kind of sometimes we repeat it a couple of times and it becomes, and we kind of remember it better. It's a high pressure system, so the air that gets pushed into the patient is under high pressure. Typically, it's just oxygen. It's additional oxygen, oxygen concentration, and nothing really else. They're short bursts, so it'll be probably like almost like half a second maybe, or a second long compression on the handle. This is what this looks like. Basically, this monitors your pressure, so you can see as you press the little lever here, it allows you some of the air. It allows some of the air to go through, and you can monitor to see how much pressure the air is under, and you can adjust how much pressure you ventilate. This connects to oxygen source, and this connects to the actual bronchoscopic ventilator. The bronchoscope has like a little couple side port attachments. As you do this, you can actually see that with each burst of air, the chest rises. So you can actually see this. So you can monitor your effectiveness of ventilation to make sure that you are delivering enough air, and you can adjust how fast you give this, and also how much pressure. So if your chest is not rising enough during the ventilation, you might have to adjust the pressure of that air so you are getting enough of the chest expansion. And then when you stop giving oxygen, then your chest wall is going to compress, and that's going to be kind of your exhalation. We talked about it's a hand control device. When I said that there are sometimes you can do very high frequency ventilation, and you can give up to 100 breaths a minute, 200 breaths a minute. Clearly, we cannot do it by hand. So there are specific machines, specific ventilators which will deliver that frequency, and they need to. There are a couple other specialized pieces of equipment that go with it, such as the catheter through which it gets delivered. It's also very specialized, so it can monitor multiple parameters. And we don't have it here. So what are some of the patient factors? For example, this is looking right through at the vocal cords. So these are the vocal cords. And then as you look through them, you see that there is a very small opening here. Typically, in a normal situation, if it's a patient who doesn't have stenosis or tumor, it's a normal airway, you're supposed to see completely widely open area right here. But here, this is probably like a pea-size airway, maybe even a little bit less than that. The problem, the problem with this patient is going to be this: is you're trying to sedate the patient, and typically the sequence is this: patient's on the table, patient gets a little sedation, they get reoxygenated, they get a little sedation, anesthesiologist ventilates them with 100% oxygen, so they have 100% of sets, and then they intubate as the patient is paralyzed. Patient with a tight stenosis, or pretty much with any significant stenosis, you're not able to ventilate them adequately just by hand. So if you hold the mask and you try to push that air, it doesn't happen. There is too much resistance. So as you're trying to prepare to intubate and ventilate these patients and do whatever it is that you need to do, patients need to be able to be spontaneously breathing. Basically, the patient's going to do a much better job initiating breaths and inhaling enough air than any machine that we have. So it's a balance between maybe sedating the patient enough that they're not going to be traumatized by somebody trying to ram a metal tube down their throat to dilate that stenosis. But at the same time, if they get too much, a little bit too much, and now they stopped initiating the breaths, then they won't be, they're going to start desaturating probably within a couple seconds. And as you can see, in this situation, you won't be able to ventilate very well. You're not going to do mask ventilation, but you also won't be able to intubate this patient. So here I have a video that I want to show you of this is what it looks like when you do bronchoscopy. So these are the vocal cords. These are I just showed you that picture. This is from a couple years ago where one of my residents was doing this bronchoscopy. So arytenoid cartilages, the false vocal cords and the true vocal cords are the little 10 color strips right there. And then just as soon as you go through the vocal cords, you see this. There is some secretions, but also there is, you'll see as it gets a little suction that there is like a pretty significant irregular area in the airway, maybe about 1 centimeter just below the vocal cords. And this is from the patient being intubated like a year before this, which triggered the stenosis just from being probably overinflated balloon on the endotracheal tube. And then you try to get through this. So this is not a very tight stenosis, but as you get through this, you kind of have to maneuver it because it's also irregular. It's not just concentric stenosis. It kind of was a step down like this. So there is a little bit of a curvature that you need to negotiate in order to see what's there. And then eventually you're gonna figure out what's where. So you can see there is this area, and once you get past this, you see that the rest of the trachea is normal, which is one of the really, this is a really nice situation. It's not a super tight stenosis. Patient is spontaneously breathing as we're doing all this. So we're able to, we have time, we have the airways pretty safe. And then after this, we stretched it out, intubated patient, and then did the tracheal resection to fix that, to reset that stenotic area and then put it back together. And this is one of the things when you asked, how do you do this, the whole duration of the case? We can't, because it's if the case is going to be more than about 1.5 hours to 2 hours, the chances of acidosis from retained CO2 becomes really high, and that's going to trigger multiple things like arrhythmias and ongoing hypoxia. Where is it? So this is what actually happened. This is one of the pictures of surgical resection, but you can see here. So initially you try to ventilate through, the patient's head is here, the rest of the patient is this way. So the patient has a small catheter through which you're trying to ventilate, for very likely either dilation with the jet ventilation, but then once you open the airway here, now you use another smaller catheter, smaller endotracheal tube, which you put through where the transection is into the normal part of the airway, so that you can ventilate either one lung or put a second one in here. So now you're still ventilating both lungs, but you're using 2 tubes to do that. And as you take this portion out and then you put it back together, now you pull these 2 things out right before you pull this together, and then you advance the tracheal tube in the normal direction and ventilate the patient that way until through the end of the case until extubation. Multiple other versions have been described, and this is, I think, just kind of shows that when you when you kind of in a tight spot, you try to come up with these alternative methods which are not used every day. We've put catheters and just kind of insufflate, and just with continuous flow of oxygen through the catheter into the either 1 lobe or 2 lobes, just as long, whatever it takes to maintain saturations in an acceptable range as you're doing a certain portion of the operation, and then you retract it back. I don't think we did that. We did something like this when we did the fistula like a couple months ago. There's like a tracheoesophageal fistula. I think we eventually put the ventilator through on the transection in the distal end, and then pull it out. I can't remember. No, I don't. No, we didn't do that. We we had a bronchial blocker in there, so that one we did with a single lumen with a bronchial blocker, and then we were just pulling the bronchial blocker once we were finishing anastomosis over there. So this is a picture of a fistula. So this is right at the bifurcation of the carina, and you can see this is the normal airway right here, but then right here, this is not a bronchus. This is a hole through the trachea and into the esophagus. So if you're trying to, and this is right at the carina, this is left side, this is right side. So if you place in the tracheal tube, which sits a little bit above the carina, and you're trying to blow air in, the air is going to go in partly in the lung, but the compliance of the lung is a little bit different. It's slower than this hole. It just goes into the stomach, and you and you are going to be first losing air. The air is going to be going to the stomach, distending the stomach, and then the patient is going to vomit on the table. If the fistula is small, maybe it's like 2 millimeters, it's too tight, so you will be able to ventilate patients in a normal way. But if you have a fistula that's like 5-6 millimeters or larger, that becomes too big of a hole through where ventilation is not going to be impacted. You will be losing a lot of air through it. No, fistula. So I'm going to say trauma, probably not the most common reason. The more common reason, probably it's malignancy. It's either cancer, or it's more likely the cancer that was treated, radiation, chemotherapy, something like that, which caused this, or airway manipulation. It's someone who had a stent that started eroding into the airway or into the esophagus. So for this patient, you try to intubate patient distal to the fistula. Basically, try to place an endotracheal tube in here, or in whichever looks like easier, maybe, or in this side of the airway, so that you ventilate that side as you prepare to operate. I think this is the left side, so you probably ended up, this is left side, the right side will be here, so you probably end up doing this, trying to ventilate this side as you're doing the operation through the right side of the chest. If you're not able to do this, this is where probably as you try to maintain ventilation, and then as you open the airway and you start working on the actual fistula, that's where you probably place these catheters distal in the lung and try to ventilate them so that you have better oxygenation. And so this basically, that's the summary. That will be very likely a combination of techniques. A number of things. Sometimes would you, if I know that something needs to happen only for a brief period of time, maybe like a minute to 2 minutes, we can just do apnea. Basically, we say, do not ventilate patient for 2 minutes. Let's wait until saturations are good, because I need it be and try to save time with all the manipulation and placing and unplacing and confirming this. Sometimes it's easier to say, just hold ventilation, do not ventilate patient. I need 2 minutes to place these 2 stitches, tie them, and we're done. So this is kind of what I have. So majority of the time we do standard thing, it's a double lumen intubation. However, jet ventilation, as hard as it can be and uncommon as it can be, it does provide, it is very helpful, especially when you have a kind of more complex cases where you can be maybe more inventive or kind of think a little bit outside of the box, how to treat it and how to provide ventilation during the case. Any questions?
Where is our setup for jet ventilation?
It's in that middle hallway. So thoracic is not the only one who uses this. So it's airway, right? So ENT will probably use quite a bit in the supraglottic area. So when they do something kind of right over here, right near the vocal cords, or just above the vocal cords. They have to, yes, when you use the manual one, yes. And that's why, again, the case cannot go on for hours, because I don't think they can really do this. So it has to be fairly fairly defined timeline. You're welcome. So